Second generation inhibitors versus crizotinib is still, I think, an open question and is being addressed in ongoing trials to actually randomize head-to-head against crizotinib. They certainly look very potent, like they in the clinic as they do preclinically compared to crizotinib. But whether they'll really replace crizotinib in the first-line setting is, I think, unknown. Certainly second-generation EGFR inhibitors looked essentially the same as erlotinib when they were compared in the first-line setting, but they also didn't have very much activity in the second-line setting. The ALK inhibitors are unique in that they have a lot of activity in the second-line setting, and at least in the first-line setting in Japanese populations, alectinib has shown really quite tremendous response rate and duration of response. So I think it is certainly possible that they may replace crizotinib ultimately, although only the head-to-head studies will tell us that for sure, whether they'll really translate into a more durable response than crizotinib has. There are planned head-to-head studies of both alectinib versus crizotinib. There's an ongoing phase 2 randomized study of the ARIAD drug AP26113, excuse me, and there are ongoing studies of cetirinib or LDK378 versus crizotinib. So all of them are being compared to crizotinib. The primary difference between the second generation inhibitors is their potency, and it was thought really that the role or the niche that they would have is for crizotinib-resistant mutations that occur within the ALK gene itself. Many of those inhibitors have very good potency against known secondary mutations that occur in the ALK gene after treatment with crizotinib. However, what we've seen in the clinical trials that have been done to date is that these agents seem to have activity across a broad spectrum of crizotinib resistance, meaning the response rates that we've seen with all of the agents have been well above 50%. We know that secondary mutations in ALK occur at a rate of 30% or so, and there's many other mechanisms of resistance that occur outside of the ALK gene. So that says to me, at least, that the issue may not be that we're just getting those resistance mutations, but that these are more potent drugs in general compared to crizotinib, and that may be why we see the activity that we do. There are a number of second-generation ALK inhibitors in development right now, and they all have greatly increased potency compared to crizotinib. It is not clear yet where they will differentiate themselves in terms of relative to one another in terms of their use. What we know preclinically is that different inhibitors have different activity against different secondary mutations, and that there may be differences in that regard. So if we really could identify the mechanism of resistance in each individual patient, we may be able to match up what is the appropriate second-generation inhibitor. However, I think realistically that may be difficult, and practically, again, what we've seen is that the potency of these agents is such that they have kind of broad spectrum activity, more than we would expect just based on their preclinical data. So I think the differentiation may come indeed in differences in side effects or potential differences in, for instance, CNS penetration. There are differences in side effects that we've seen. Cetirinib, which is probably the furthest along in development, also has had significant toxicities, particularly GI toxicities, which have very frequently resulted in dose reductions for a large number of patients from the recommended phase 2 dose. Alectinib, on the other hand, has had actually quite minimal toxicities and hasn't had a real issue with dose reductions and was able to be advanced quite beyond the recommended phase 2 dose without a lot of difficulty. So that may play out as we get more data from more patients in terms of choosing one versus the other. In terms of CNS penetration, it's not yet clear what the differences are between the different agents. It is felt by the makers of alectinib, Roche, that that may have preferential activity in the brain because it is not a PGP substrate, unlike crizotinib and some of the other agents in development. Whether that will really make a difference in terms of the CNS efficacy, we don't know yet. We're still quite early in actually evaluating CNS efficacy. One of the newest molecules in development, which is an ALK and ROS inhibitor from Pfizer, has particularly high levels within the CSF and was actually developed to be able to cross the blood-brain barrier. So that may differentiate itself from all the others, but it's too early to know that yet.